Good evening, everybody, and welcome to this webinar on interesting case studies, how to approach morphological findings. See, I had sent 8 cases with history and one picture at least of each case. And majority of you have responded and sent your diagnosis. So what I'm going to do is discuss those diagnoses, and it is very heartening to inform you that majority of you have made at least 6 diagnoses correct, and maybe
Wow.
the pat comes to me, or the students themselves have been too good that they could pick up all the lesions, and the diagnosis is in some of the cases they've given as correct as up to say the deletions also that are at the cytogenetic level. So it was very heartening to see the diagnosis. So without wasting much time, I'll start with case number 1. Now, this was a 35-year-old male who was admitted with pallor, lassitude, weakness. Patient had spleen of 1 centimeters, low hemoglobin of 7, TLC was low with 1900, and neutropenia, polymorphs were 23. But there were atypical cells, 6%. Now, this is a very important finding that the patient has low TLC, the cells are too low, and yet there are atypical cells with 6%. And those atypical cells were blastoid. And therefore, considering the fact that the patient has a low count, but the blastoid cells are present, which therefore the diagnosis of subleukemic leukemia was thought of. Now, this was the picture given. This was bone marrow aspirate. And as you can see in the bone marrow aspirate, all these cells are atypical cells. Now, if you look at these cells, these are large. They have an open chromatin, basophilic cytoplasm. All the cells had basophilic cytoplasm. Occasional cell here had cytoplasmic vacuoles. Some of you have given even the diagnosis of L3. Now, in ALL L3, what we find is that the cytoplasm is basophilic and it is a homogeneous chromatin. Nuclei are prominent, but these vacuoles are seen in nearly each and every cell, which were missing in all these. Then some of you have given the diagnosis of AML. Well, it could be AML. There is no reason why it cannot be AML, but the only thing is that the cytoplasm is basophilic, which we usually don't come across in M0, M1, M2, M3, M4. Even in M5, we don't come across. The only cells which demonstrate a basophilic cytoplasm is M6 or erythroleukemia. So this was a thing. So these are the diagnoses which I got from you. Acute leukemia, megaloblastic anemia. See, megaloblastic anemia is a very pertinent diagnosis considering the fact that majority of the cells had open chromatin, basophilic nuclei. Some of you have written even viral infection. Now, in viral infection, we find plasmacytoid cells, monocytoid cells, and blastoid cells. But here the cells were only blastoid. There were no plasmacytoid. There were no monocytoid cells. Some of you have given the diagnosis of ALL, L3. Some people have written. Aplastic anemia, it is not, because in the peripheral blood, there were blastoid cells, and in the bone marrow, the section which was provided to you did show these blastoid cells. Some of you have given the diagnosis, rather many of you have given the diagnosis of M7, and some of you have given the diagnosis of M6. Now, M7 probably because, as you can see in some of the cells, there was cytoplasmic budding. So this cytoplasmic budding is seen in M7. But in some other leukemias also one may come across these tiny cytoplasmic protrusion. So only the presence of these cytoplasmic buds does not make it M7, but yes, it is a very good differential diagnosis. M3 I did not think of because of the fact that the cells were not showing any granules. It was not a hypergranular cytoplasm. At the same time, there were no OR rods in any of the cells. And if it is a variant type, then usually the nucleus is buttock shaped, which was not there in these cells. Some people had thought of even CLL and hairy cell leukemia. Now the cells are too large for CLL as well as hairy cell leukemia. Now this is the other picture of this case, where again you find that cytoplasm is basophilic, open chromatin, and prominent nucleoli. Then you find binucleated cells. There were some quadrinucleated cells also. There were very, very few eosinophils, but this was the picture given to you. So what we had was hypercellular marrow, sheets of blast cells, myeloid, erythroid, and megakaryocytic cells. All of them were diminished. So first of all, going on to the cytochemistry, the myeloperoxidase was negative, Sudan black B was negative, non-specific estrase was negative. What we found was the positivity with PAS stain. You can see this is a PAS stain. The cytoplasm is showing us pinkish granules. Now, such pinkish granules in the blastoid cells are seen in cases of AML M6. This is the biopsy, and what biopsy shows is sheets of these blastoid cells. You can see the prominent nucleoli in these cells, and there are very, very few eosinophils, but mainly it is the cells. Megakaryocytes are diminished. Very few polymorphs are seen. The myeloid cells are diminished. The erythroid cells are diminished. So we know it is an acute leukemia. There is a cellularity of 90 to 95%. And then what we had to embark upon was confirm the diagnosis, since we didn't have bone marrow left. So we could not do the flow cytometric analysis. So on the bone marrow triphyine biopsy, we thought it is an acute leukemia. So we put up markers for acute leukemia. Now you can see CD34 for acute leukemia negative, CD3 and CD20 for T and B cells were negative. Now PAX5, CD10 were also carried out, and also CD79A for ALL. Now those are all negative. And this is CD71. You can see all the cells demonstrated positivity with CD71. Now this is not only that, we also found that it was negative for myeloperoxidase, but it was positive for CD117. Now, since CD117 is the marker which is positive, not only in the erythroblasts early, and that too in proerythroblasts. So that means we were dealing with a case of either proerythroblasts or a case of AML M0 or M1, in which the blastoid cells could be CD117 positive. So there were two possibilities left. But the CD71 staining confirmed more of proerythroblasts, and then it was confirmed by doing E-cadherin. So these three markers clinch the diagnosis that it is CD71 erythroid, proerythroblasts, and CD117 also positive in proerythroblasts, and E-cadherin is positive in proerythroblasts. And therefore, we made a diagnosis of acute erythroid leukemia, or M6. Now, this is a new entity as per WHO 2017. Earlier, we had M6A and M6B. Now we know that M6A is MDS, while M6B is actually the pure erythroid leukemia, and the criteria are more than 80% erythroblasts, out of which more than 30% should be proerythroblasts. But here in our case, there were about 60 to 70% proerythroblasts, and CD34, HLA, DR, MPO, these were all negative. Only these three markers were positive. confirmed, and they were also past positive. Now, at times in differential diagnosis, it could be AML M7, which many of you have written. Some of you have written even AML M0, which is all correct. Some of you have even thought of megaloblastic anemia. I think this is a differential diagnosis with which we always get confused, because in megaloblastic anemia also we will come across such early erythroblasts or proerythroblasts, but then their number is not usually more than 30%. We come across early erythroblasts, but not proerythroblasts. So all these differential diagnoses have to be taken into account for labeling a case or what is the type of acute leukemia. So this was a case of M6. Then we go on to case number 2. Now this was the picture given and the history. 58 years male, admitted with dragging sensation, left hypochondrium, indicating that spleen is enlarged, weakness, peripheral blood showed low hemoglobin of 9, TLC was increased, as you can see, 40,000, platelets normal, 2 lakhs. But what we find here are promyelocytes, myelocytes, metamyelocytes, polymorph, basophilia, 3%, eosinophilia, 3%. Now, all these features and the picture what you are seeing is highly suggestive of that we are dealing probably with a case of CML in which the platelets are normal, TLC is high, but it is not in lakhs. Usually we find the count to be between 1 and 3 lakhs, which it is not. And there is basophilia and there is eosinophilia. So the possibility of CML was considered. Now this was the biopsy given to you. And what does this biopsy show? Again, it is almost 100% cellularity. That is one. Second thing you find is there is fibrosis of the marrow throughout. And there is extensive marrow fibrosis. Not only that, there is a granulocytic hyperplasia and megakaryocytic hyperplasia. The erythroid precursors are diminished. So fibrosis, granulocytic, megakaryocytic hyperplasia, and many of them, rather majority of them, are dwarf megakaryocytes. So the diagnosis which I have received from you are CML. I think majority of you have given the diagnosis of CML. And then PMF, primary myelofibrosis. Again, good number of you have given PMF. Some have given ET, thinking probably the essential thrombocythemia. And many of you have written CML with fibrosis. That is what it is. This is a case of CML with extensive fibrosis. And nowadays, WHO uses the word CML advanced phase, in which there is a granulocytic and megakaryocytic hyperplasia along with extensive fibrosis. Now that is called advanced phase. And those cases, they go on to blastic phase very soon or accelerated phases very soon. Now this is on bone marrow aspirate, a typical picture from such a case where you find granulocytic hyperplasia. This is a bone marrow aspirate in 2 cases. And then you find megakaryocytic hyperplasia. And then you are finding all the megakaryocytes in this are dwarf megakaryocytes. They're smaller and hypolobated nuclei. Again here, hypolobated nuclei, which is a typical feature, as I told you, of CML. Whenever we talk of myeloproliferative disorders, we look for dwarf megakaryocytes, granulocytic hyperplasia, and the erythroid are diminished. So this is highly suggestive of a case of CML. And this, of course, was the bone marrow biopsy, which was given to you. Reticulin we can find from grade 2 to 3. Collagen fibrosis also can occur. If we go to the old reticulin grading, then it could be even up to grade 4. Now, some cases you find streaming is very, very obvious, as you can see here. Tremendous granulocytic hyperplasia, megakaryocytic hyperplasia is focal. But what is clinching is this reticulin fibrosis throughout the marrow and the dwarf megakaryocytes. So we know that WHO has given that the CML, it is a granulocytic hyperplasia, but in advanced phases, we find granulocytic and megakaryocytic hyperplasia with myelofibrosis. And these cases soon go into accelerated phase, what we call as the advanced phase of CML. So the differential diagnosis, I think, is very, very nicely taken by all of you. And many of you have written that granulocytic megakaryocytic hyperplasia or the advanced phase of CML. And differential diagnosis, of course, is primary myelofibrosis. So what we have to do in such cases is BCR-ABL. See, it is essential to diagnose CML before we institute imatinib. So had we done BCR-ABL, the diagnosis becomes clear. CML, BCR-ABL will be positive. PMF, JAK2 or CALR will be positive. Now this is what only granulocytic hyperplasia or early stage of CML. This of course is granulocytic and megakaryocytic hyperplasia. So how do we differentiate? See, the TLC is high. Here the TLC may be normal or low. Leukoerythroblastic blood picture appears in PMF. That is what we keep on teaching our undergraduates. But the clinching thing is BCR-ABL is negative. That is positive. Here JAK2, CALR, etc. will be negative. One of them will be positive. And then in PMF, I had insisted you that clustering of megakaryocytes is very, very important. So in this particular case, there was no clustering of megakaryocytes. So the diagnosis of CML was given. Now this is a picture of a PMF where we find these teardrop cells. That is number one, which is classical. Second thing is leukoerythroblastic blood picture in which we find nucleated RBCs, and we also find myelocytes and metamyelocytes. And of course, one of these driver mutations, JAK2, CALR or MPL. Now this is PMF. Then we go on to case number 3. Now this was a 42-year-old male admitted with fever, weakness and pallor of 2 months duration. No liver, no spleen, no lymph nodes, not looking well. Low hemoglobin of 6. TLC was again low, 3000. Platelets 42,000. So patient had pancytopenia, LFT normal, but no liver, spleen or lymph nodes. Urea was increased, 92. Creatinine was increased, 3.8. And the bone marrow aspirate was carried out. And that is what we found on the bone marrow aspirate. What we are seeing are large cells. That is number one. They appear blastoid, okay. But then the cytoplasm is much more than we come across in usual blastoid cell. There the cytoplasm is less. Nucleoli are very, very prominent. Could it be NHL? Yes, it could be a large cell NHL. It could be anaplastic large cell lymphoma. Could it be acute leukemia? It could be acute leukemia also. If they are in clusters, yes, it could be even metastatic deposit. So this is a picture which can be seen in any of these differential diagnoses. And PET CT showed some lytic lesions, and then the bone marrow biopsy had been done. Now I got from you people the diagnosis of multiple myeloma. Many of you have given the diagnosis of multiple myeloma plasmablastic. Then some have given the diagnosis of ALL, M7, M6. Yes, it could be M6. M7 chances are dim, but you never know. And then some people have thought that these are giant proerythroblasts. So they've given the diagnosis of parvovirus B19 infection. I must say that the giant proerythroblasts are not in clusters as we were seeing in this particular case. Now this is the bone marrow biopsy. Now what I find on the bone marrow biopsy are large cells, number one. You can all see large cells, round to oval nuclei, very, very prominent sort of eosinophilic nucleoli was seen. Now, though many of you have given the diagnosis based on the morphology of bone marrow aspirate, it is excellent. See, because usually if we get only such a biopsy, no bone marrow aspirate, they look like any other large cells. Could be blast cell, could be undifferentiated carcinoma, could be melanoma, could be even multiple myeloma plasmablastic type. Actually, such a case of plasmablastic, the first case I reported 10 years back, when we had good number of markers, only then we could report, because it looked like acute leukemia. Markers for acute leukemia turned out to be negative. Markers for lymphomas turned out to be negative. For metastatic deposit turned out to be negative. And then I thought that could it be multiple myeloma? I read the book, and there they had given the plasmablastic type of myeloma is also there, where we find these prominent nucleoli and the morphology you have seen. And then I gave the diagnosis of plasmablastic multiple myeloma. So it is heartening to see that many of you have diagnosed multiple myeloma of plasmablastic type. Now, these are the various markers which were carried out. All of them were negative except for CD138, that was positive. EMA was positive, which comes positive in multiple myeloma. Then kappa was negative, only lambda was positive. Now that is important. This is CD138. You can see all the cells are CD138 positive in the biopsy. Here, this is lambda. These are the erythroid precursors, some lymphocytes, which are all negative. But these atypical cells, all of them demonstrated lambda positivity. Kappa was negative. So based on that and considering the morphology, of course, the differential diagnosis do remain carcinoma, DLBCL, Burkitt lymphoma, till the time you do the various markers and confirm that we are dealing with a case of multiple myeloma, plasmablastic type. Now, Kyle and Greep, they say that if there are 2% or more plasmablasts in the marrow, this is an independent adverse prognostic factor. Now, this is very, very important. And these cells have to be differentiated from immature plasma cells. I'll show you. So the plasmablastic multiple myeloma is a masquerader because of the large blastoid appearance and of course the prominent nuclei. But these markers will clinch the diagnosis. Now I showed you when we discussed about multiple myeloma. Now these are the immature type. Here the cells are plasma cell-like. The morphology is there. Nuclei are very large. They have very, very prominent nucleoli. So these are immature plasma cells. On the other hand, the plasmablasts which we have seen, they do not have eccentric nuclei. They have a central nuclei. And that is how we differentiate the immature plasma cells from the plasmablasts. This, of course, is a pleomorphic type, all shapes and sizes. And because of the various shapes and sizes, we mistake them for metastatic deposit. This is intermediate type. This is again pleomorphic type and associated with extensive marrow fibrosis. And again, it looks like a metastatic sarcoma or metastatic carcinoma. Then we go on to case number 4. Now, this was a 48-year-old male who presented with a mass on the left side of abdomen, indicating that spleen, weakness, loss of weight, 4 months, pallor is positive, no bleeding manifestations, TLC was increased. Now this was the smear given to you was a peripheral smear where the TLC was high. This is a lymphocyte, and what do we find is 1, 2, 3, 4 are large cells, 5th also. These are large cells, but all of them have different morphology. They are not similar in morphology. Chromatin is open, but all of them have got prominent nucleoli. Some of the cells have notching, as you can see, and occasional cell had cleave-like picture also. So whenever we find pleomorphic morphology, the possibility of lymphoma spillover cannot be ruled out, but this patient had no lymph nodes. There was only a mass on the left side indicating their spleen. And such cells were large, and they were 35%, and all of them were larger than, of course, the lymphocytes. This is a bone marrow aspirate. Now, this was a hypercellular marrow. Myelopoiesis, erythropoiesis were diminished. Megakaryocytes were present. And then you find these large cells. They were present depending upon various areas of the bone marrow, 35 to 50%, with pleomorphic morphology. These are the erythroid precursors. These are few myeloid precursors and polymorphs. Now, this is the bone marrow triphyine biopsy. Now, looking at the triphyine biopsy, if I don't have any history or anything, I would say that it is a diffuse replacement of the bone marrow by these atypical cells, which are larger than lymphocytes, and they have an open chromatin, but the nuclei are not seen in these cells. So indicating that probably we are dealing with a case of lymphoproliferative disorder. So the diagnosis which I got from you was acute leukemia. I think it was a very good differential diagnosis. Some of you have given the diagnosis of hairy cell leukemia. Of course, there was no typical appearance of fried egg appearance. M4, yes, one can think of. And some of you have given the diagnosis of lymphoma spillover. And I was surprised because this is the correct diagnosis. And this is what this case was. And some of you have given even METs. Now, METs coming into the peripheral blood is very, very uncommon. There is carcinocythemia. That is a term we use whenever there are metastatic cells present in the peripheral smear. Now, this was a diffuse infiltration in the bone marrow, and that is what the picture was. You can see these cells do not have rounded or oval nuclei. Many of the cells have got lobulated and even notched nuclei. Some of you have given even the diagnosis of monocytic leukemia. So the differential diagnosis was, it could be SLVL, Waldenstrom macroglobulinemia, PLL, hairy cell leukemia, NHL spillover, mantle cell lymphoma, splenic marginal zone lymphoma, or even polyclonal B-cell lymphocytosis. If you have a look at the biopsy, this diagnosis is ruled out. We know it is one of the lymphoproliferative disorders. Now, how to confirm is that we must apply various markers on the bone marrow trephine biopsy. That is the advantage of a bone marrow trephine biopsy, that if you have done a biopsy, you can apply various markers. Now, this case turned out to be CD20 positive, so we know it is a B-cell lymphoma. CD5 positive, that means CD20 positive, CD5 positive, then we must go for CD23. Now, here the CD23 was negative. Now, CD23 negative, that means CLL is ruled out, or small cell lymphoma is ruled out, because in that we find CD20, CD5 and CD23, all three positive, which were not there. CD23 is negative. Now, negative CD23 but 5 and 20 positive is highly suggestive of mantle cell lymphoma. And secondly, since CD34 were negative and CD10 were negative, we knew that this is not a precursor B-cell neoplasm, but this is a mature B-cell neoplasm. And BCL6 was negative, ruling out Burkitt. CD10 was negative, which ruled out follicular lymphoma. And this is CD23, that was negative. Cyclin D1 turned out to be positive. Cyclin D1 is a nuclear stain, and you find all the cells are positive. So mantle cell lymphoma, this it was. Cyclin D1 positive. And since the cells were larger, blast-like, this is a blastoid variant, indicating CD23 negative, 19 and 20 positive, and CD5 positive. Now, WHO 2017 has, this is an aggressive neoplasm of B cells. And now we know there are three variants: classical, leukemic, non-nodal, and in situ mantle cell lymphoma. There is another marker which has come up, which WHO advocates, is SOX11. If it is positive, it is more in favor of classical. If it is negative, it is more in cases of leukemic non-nodal mantle cell lymphoma, and that is usually indolent. But overall, mantle cell lymphoma has got a worse prognosis. Therefore, we must differentiate it from other lymphoproliferative disorders. Now, this is from WHO, where we find that these cells from the mantle zone, they proliferate. It may be a lymph nodal enlargement, or it may be extranodal. It could be a pleomorphic mantle cell lymphoma. It could be small cell type. It could be a blastoid cell type, or it could be limited to the peripheral blood, bone marrow, and spleen. Then we go on. Now, this is to differentiate from CLL, because usually most of the mantle cell lymphomas are small cell type. Now, this is a picture of CLL, not of mantle cell lymphoma. Here we find that majority of the cells are lymphocytes, but there are some pro-lymphocytes. But these pro-lymphocytes are less than 10%. And then we come across some smudge cells in the peripheral blood. And as I told you that mantle cell lymphoma, the diagnostic is cyclin D1 is positive along with CD20 and CD5 on immunohistochemistry. Now this is follicular lymphoma. In the follicular lymphoma, we come across paratrabecular NHL involvement. You find the deeper marrow is normal. The lymphoma is limited only to the paratrabecular area. And this is a paratrabecular area. This is CD10 positive. Now the follicular NHL are CD10, CD20 positive, along with, of course, the BCL2 like that. So that is what it is on bone marrow trephine biopsy. So that means if you have got lymphoma deposit in the bone marrow biopsy, with the help of markers, we can differentiate one from the other. Then we have one villous lymphocytes. If these are seen, that is seen in splenic marginal zone lymphoma. If we come across plasma cells along with plasmacytoid lymphocytes, it could be what we call as Waldenstrom macroglobulinemia or lymphoplasmacytic lymphoma. So that means these are all coming under a major group of mature B-cell lymphomas. Now, all of them have different prognosis. So what is needed is correct diagnosis. And therefore, we should do either immunophenotyping on the trephine biopsy, or one can do a flow cytometric analysis of bone marrow aspirate and the examination of the peripherals. Then we go on to case number 5. 70 years old gentleman, retired from government as Secretary, Government of India. And 10 years back, he retired. He had pallor, weakness, tiredness for 2 years. No organomegaly, no liver, no spleen, no lymph nodes. Hemoglobin was gradually decreasing and now it was 8 grams. TLC normal, 4,000. Differential nearly normal, polymorphs 55. Platelets slightly on the higher side, 3.9 lakhs. And he was very, very intelligent, and he gave me the name of the drugs, that all these drugs, hematinics, B12, folate, iron, everything he had been taking for last 2 years, but no response. He had refractory anemia. So the first thing first, this is a peripheral smear which was given to you. It shows simply macrocytosis. So this patient had macrocytic anemia. Now his serum ferritin was normal, Coombs negative, HPLC normal, no signs or symptoms of infection, just to rule out any anemia of chronic disease. That was not there. Kidney function tests, LFT were normal, retic count 1%, clinical impression refractory anemia. So we advised him bone marrow aspirate and biopsy. Now this is the picture I had given to you. So what you find here are, these are the erythroblasts, and in between there are erythroblasts. So normoblastic reaction, but you find majority of the cells are myeloid. So there was sort of erythroid precursors were diminished. I expected that since he had anemia of 8 grams, the marrow should be responding. But the marrow is not responding. You find erythroid precursors are diminished. Myelopoiesis, normal. There were a good number of polymorphs, metamyelocytes. So myelopoiesis was okay. Look at the megakaryocytes. Megakaryocytes were plenty. And a good number of megakaryocytes were seen. I would say there was megakaryocytic hyperplasia. And this was on aspirate. What I found was the cytoplasm is mature. I told you that the granularity of the cytoplasm appears as the megakaryocytes mature. So what I find is that the nucleus is not lobulated as it should be in a case of normal megakaryocyte. This was rounded. Here there was a slight notch, but in majority of the megakaryocytes, this was just a rounded eccentric nucleus in almost all the megakaryocytes. Now these are the diagnoses I got from you. Kala-azar, majority of you have labeled it as MDS, which is a correct diagnosis. Though, of course, some of you have given the genetic workup also. Autoimmune hemolytic anemia, that was another one. Megaloblastic anemia, I may not agree, because in both of them, what you find is there is megakaryocytic hyperplasia, erythroid hyperplasia in autoimmune hemolytic anemia, as well as in megaloblastic anemia. But to my surprise, many of you have diagnosed it correctly as 5q deletion. Now, this is what the bone marrow biopsy showed. There is cellularity is not very high. It was about 60% cellularity. Myeloid precursors are there. Some erythroid precursors are there. Foci were present. Look at the megakaryocytes, hyperplasia of the megakaryocytes. Not only that, look at the nuclei of each megakaryocyte. They are of normal size, but eccentric, small, round to oval nucleus. That is a typical feature of MDS 5q deletion. So we got the cytogenetic done, we got the FISH done. Both of them showed 5q deletion, confirming the diagnosis that we are dealing with here. Now, this is one type of MDS which can easily be diagnosed on morphology, and it can be confirmed on cytogenetics or on FISH studies. The importance is that there is a very good response to lenalidomide, and these patients, they become transfusion free. Now, that is the most important thing. And these cases present with refractory anemia, and many of them present with thrombocytosis. Now, this particular case also had anemia with thrombocytosis, and the blast cells are less than 5%. Marrow erythroid hypoplasia, there is no hyperplasia at all. So this was a case of 5q deletion, and many of you could diagnose as 5q deletion, which was very, very heartening. Now, good prognosis, hypolobated or unilobated nuclei, and then lenalidomide is one drug which not only takes care of anemia, but it reverses the cytogenetic and morphological abnormalities also. Then we go on to case number 6. This was a 9-year-old child admitted with pallor for 2 weeks. He was diagnosed a case of ALL 6 months back. He was on maintenance therapy. Blood showed low hemoglobin of 8. TLC, DLC were within normal limits. Platelets were adequate. Hematinics were given, but no response. Retic count was 0.2%. Now, since this was a case of ALL diagnosed 6 months on maintenance therapy, sudden fall in hemoglobin from 12 grams to 8 grams, we thought that the patient had relapse of ALL. So we advised a bone marrow examination. But what was troubling was this reticulocyte count. Reticulocyte count was less than 1%. In a recovering marrow, we usually come across 1 to 5% of reticulocytes, but here they were less than 1%, indicating that probably there is some erythroid hypoplasia. Now, this is the bone marrow slide I had given you, which showed normal megakaryocytes, normal morphology. Look at these cells. Lymphocytes are there, not as many. And then you find these myeloid precursors. All of them are myeloid precursors by and large. And there were no erythroid precursors present in the whole slide or the whole picture which I had given you. What you find here is one cell which is large, which has got basophilic cytoplasm, prominent nucleoli, and open chromatin. Now, this could be a case of giant erythroblast. If it is giant erythroblast, obviously it is a case of parvovirus B19 infection. And the lymphocytes which are in the marrow, so number 1, he's a child. Number 2, recovering from ALL, where there is a rebound lymphocytosis. Rest, everything is explainable. So even if this is not there, looking at the megakaryocytes, looking at the myelopoiesis, it was highly suggestive of a pure red cell aplasia. The only thing was we had to rule out whether there were many more of these giant erythroblasts or not. Now, this is the diagnosis I got from you. ALL relapse. Of course, we also thought of ALL relapse, but there were no blast cells in the bone marrow smears. ET is not, this is a diagnosis because ET we find in old age. Hematogones, some of you have written, those are not hematogones. Those are larger than lymphocytes, but here these were all lymphocytes. CLL again is a disease of old age, so we don't come across. Diamond blackfen is a very appropriate diagnosis because diamond blackfen we find pure red cell aplasia. Maybe some cases go on to aplastic anemia. But yes, Diamond-Blackfan syndrome is one in which we come across pure red cell aplasia along with lymphocytosis of the bone marrow, which was present in this case. Some of you have written bone marrow suppression, but then it was only the erythroid series which was suppressed, not the other one. Now, this is the slide I had given you, and this is a high-power view of another feed where we could see every 100 cell turned out to be a giant proerythroblast, which have got a typical morphology of basophilic cytoplasm, open chromatin, prominent multiple nucleoli, inclusion-like nucleoli are seen. Some of the cells do show cytoplasmic protrusion, what we call as dog's ears like of protrusion. And what you find are these are all myeloid precursors, some lymphocytes, no erythroid precursor. So we had, this is the cytoplasmic protrusion we come across in these cases, and that is what gives the appearance of dog's ears. And then, of course, again, you find myeloid precursors are present. So this is transient red cell aplasia. Now, due to parvovirus B19 infection, whenever we talk of hereditary spherocytosis or we talk of sickle cell anemia, we say that there could be an aplastic crisis. And that aplastic crisis is due to parvovirus B19. And in these cases of parvovirus B19, then the marrow regenerates very fast, and then you find that it is repopulated by erythroid precursors. So there could be a transient red cell aplasia. Similarly, transient red cell aplasia can also occur in cases of viral infection, bacterial infection. So what we should look for in any case of red cell aplasia is look for giant erythroblasts. If they are present, this is a case of parvovirus B19 infection. Otherwise, we can get a serology done or PCR test done for parvovirus B19 infection. This is on the bone marrow trephine biopsy. You find the myeloid cells, and then you find this large cell, similar to what you have seen in the bone marrow aspirate smears, and an inclusion-like nucleolus. That is a typical picture on bone marrow trephine biopsy. If you have any doubt, you can apply CD71 because CD71 will confirm these are the other myeloid precursors. It will confirm that we are dealing. Again, similar nucleolus you will come across in these cells. So the learning point is that the low reticulocyte count, because low reticulocyte count is highly indicative of two diseases, aplastic anemia and pure red cell aplasia. So look for giant proerythroblasts. But keep in mind that parvovirus by and large causes pure red cell aplasia, but at times it may also cause, in addition, leukopenia, thrombocytopenia, and rarely even pancytopenia may occur. Then we go on to case number 7. 7-year-old child admitted with fever, lassitude, delayed milestones. Now, this is a very important finding, and mild splenomegaly. And the patient had bicytopenia, that is anemia as well as leukopenia. And this is the smear I had given you. Now, this is a hypercellular marrow. You are finding these erythroid precursors. Of course, they are diminished as compared to the myeloid precursor, but good number of them are present. Megakaryocytes are present. They are normal. Then you are finding 2 macrophages. Now, this macrophage has got foamy cytoplasm and granules like sea blue histiocytes. This is bluish cytoplasm, but foamy cytoplasm. So we had macrophages with foamy cytoplasm, macrophages with sea blue granules, and the history was there. So majority of you have given the diagnosis of storage disorder. Now, these are rare disorders. Some of you have given even the diagnosis of Niemann-Pick disease, the correct diagnosis. Though, of course, I don't know how many cases you have seen, but looking at the morphology, I was very happy that majority of you have given storage disorders and some of you have given even Niemann-Pick disease. Few of you have given Gaucher's disease, HLH, pure red cell aplasia, as well as megaloblastic anemia. So let's see, this is the same picture. Here, this is what the picture was. Foamy cytoplasm, you find this vacuolated cytoplasm. Now, this is typical of Niemann-Pick cells. This is another Niemann-Pick cell, but this is a typical small nucleus, large macrophage, and showing you these vacuolated cytoplasm. Now, sometimes there could be problem in differentiating these macrophages from Gaucher's disease, Langerhans cell histiocytosis, acquired Gaucher cells, or even Waldmann's disease. Now, this is the bone marrow trephine biopsy. You find these are the erythroid precursors, myeloid precursors are present, and then you find these clusters of cells. All these cells are showing very nice fine vacuoles in the cytoplasm. Uniform vacuoles are seen. Scattered myeloid precursors, erythroid precursors are present. Now we know that the Niemann-Pick disease is of 4 types: type A, type B, type AB, and type C. Now type A is infantile, failure to thrive, and they manifest at 3 to 6 months of age, and it is neuropathic. And such children die by 3 years. Type B is non-neuropathic. Children are affected. Now this was probably a type B1, in which we find Niemann-Pick cells as well as some subleukocyte granules are seen. Type AB is clinically between type A and B, and type C is a chronic neuropathic form, and in which there is a less severe hepatosplenomegaly, and they present as ataxia. So here the diagnosis was Niemann-Pick disease. Gaucher's disease, I had shown you the smears as well as a biopsy, where you find that typical crumpled tissue paper appearance is seen, and those cells are PAS positive. While in Niemann-Pick, these cells are positive with Sudan 3, oil red O, and Sudan black P. Acquired Gaucher cells are seen in CML, thalassemias, and we label them as pseudo-Gaucher cells also. Waldmann's disease is rare, but of course in Middle East, we do come across, and once in a while we come across. Here also the cytoplasm is vacuolated, but the cells are slightly smaller. Then I go on to the last case. This was the history given: 12 years old child with intermittent anemia. Spleen was palpable. And this child required 4 red cell transfusions so far. This is a blood picture. You could see an isopoikilocytosis, moderate degree. Cells are small. Hypochromia, or the central pallor, is 3/4. It is only the ring of hemoglobin which is seen. So this is microcytic hypochromic. Then you find that in the central part, you find hemoglobin. So these are the target cells. In between, you find some teardrop cells are present. There were some 5 nucleated RBCs. Now, overall, this is a picture which is suggestive of hemoglobinopathy, and it could be thalassemia intermedia because the presentation is at 12 years of age. Had this child presented earlier, say in first year and first 3 years of life, we could have thought of thalassemia major, and but this was that is what we thought. And the red cells were of course diminished, 4 million, and hematocrit is low. MCV is very, very low, 61. MCH was 17, MCHC 27, platelets were normal. But look at the RDW, indicating an isopoikilocytosis. RDW CV was 31. So this was a case of microcytic hypochromic anemia with target cells, with teardrop cells, with nucleated RBCs, suggestive of the fact that probably we are dealing with a case of HPLC. Now, this is the diagnosis. Again, it was very, very heartening to see that many of you had diagnosed it as thalassemia intermedia. This case actually did correspond to thalassemia intermedia. Some of you have given the diagnosis of thalassemia trait. Iron deficiency anemia, it is a very good differential diagnosis, both of them. Sideroblastic anemia, yes, you can come across a similar picture. And then I was amazed that the 4 of you have given the diagnosis of HBH disease, which is a correct diagnosis, but how you have given on the basis of morphology, it was really surprising. Anyway, this is what the differential diagnosis is. You find here the nucleated RBCs, microcytic hypochromic picture, teardrop cells. So the differential diagnosis, as all of you have given, iron deficiency anemia, thal trait, thalassemia intermedia, thal major, presenting later, other hemoglobinopathies like HBE thalassemia, and rarely we come across anemia of chronic disease, but there we don't find the target cells. So thalassemia major, one comes across a few target cells. Now this is the reticulocyte preparation. And in the reticulocyte preparation, what you find are these golf ball-like inclusions in the red cells. Uniform size. These are the blue granules which you are seeing, golf ball-like appearance. Now these are the HBH inclusion. See, whenever we do a reticulocyte preparation, you should always be looking for, in such cases of microcytic hypochromic anemia, that there could be HBH inclusions if it is a case of HBH disease. Now that once we do the HPLC, you come across the band for HBF, which is at the beginning of the chromatogram. Now this is a case of thalassemia trait. Why we say thalassemia trait? No, sorry, this is a case of iron deficiency anemia, where again you find microcytic hypochromic picture, but you are not coming across target cells. Target cells are missing, nucleated RBCs are missing, platelets are increased, because some cases of iron deficiency are associated with thrombocytosis. And then you look at the RDW, CV is 20.8 or around about 21. Now, this degree of anisopoikilocytosis is seen in iron deficiency anemia. Now, what happens in iron deficiency anemia is, the first indication of iron deficiency anemia is that anisocytosis develops in normocytic normochromic cells. So you find some smaller, and some larger red cells. Second indication is that these red cells show microcytosis. Now the same cells, they show microcytosis, cells become smaller. And the third indication is that the smaller red cells now appear hypochromic. So that is how the iron deficiency anemia develops, from normocytic normochromic going on to microcytic hypochromic. They are of variable size, and you also find microcytic hypochromic picture. Now this is the bone marrow morphology, where you find typical micronormoblastic reaction, and there is a fraying of the cytoplasmic borders. What is clinching the diagnosis is a bone marrow iron. Here you find that the bone marrow iron is nil. There is no bone marrow iron in this. So iron is nil in iron deficiency. Now the other differential diagnosis many of you have given is thalassemia trait. Yes, it could be thalassemia trait, in which we find again red cell count becomes high. See, the red cell count becomes high, and we also come across that the RDW is low. It is 16. So RDW is usually low in thalassemia trait. And then what clinches the diagnosis is HPLC, where you find that the HbA2 is 5.9%. So simply saying microcytic hypochromic anemia does not solve clinician's problem. And so we have to do HPLC to rule out thal trait, thal intermedia, or HBH disease. And for postgraduates, sometimes you find, in some cases, post-splenectomy smear you will find, where you find these are the Howell-Jolly bodies. Many of the red cells will show you Howell-Jolly body. And if you are able to pick up a sickle cell here, that means this could be a case of autosplenectomy, in which what happens is the spleen undergoes multiple infarcts and it disappears. So it works, it appears the blood picture is like in a case of splenectomy. So you find sickle cells and the red cells with Howell-Jolly bodies, nucleated RBCs, marked anisopoikilocytosis, and too many target cells. So the message is that degree of anisopoikilocytosis, RDW, gives us an idea whether we are dealing with a thalassemia trait or we are dealing with iron deficiency anemia, thiol major, or HPH disease. But keep in mind that P5N deficiency, pyrimidine 5 nucleotidase deficiency, here you find that the cells show basophilic stippling, like you find in lead poisoning. And whole jolly body we find in post-splenectomy and all. So with this, I finish, and thank you very much. Now, these are the two books. This is Essentials of MD and DNB Pathology Practical Exam. How to go about the practical exam, what cases you get, what questions are asked, what answers are given. So this is sort of a key to MD DNB practical exam. Now, second edition is about to come. So I think in January, this is a multi-author book written by me and Dr. Geeta Jairam, who is on the screen today. She is a great cytologist along with Dr. Neeta Khurana at MEMC. We were all together at MEMC. And Neeta Khurana has written the histopathology part. Dr. Geeta has written the cytology part. And I have written the hematology part. And then Dr. Geeta has taken out a book recently, about a month back, Atlas and Text of Breast Cytology. It is beautifully written, and those who are dealing with breast cytology, all of you are dealing with breast cytology every day. So all of you will be needing this book to go through and how to differentiate one entity from the other, have the differential diagnosis, and then arrive at the correct diagnosis. Thank you very much.
Thank you, Dr. Tejinder Singh. There are still some questions if you would like to take up.
Okay, I'll take some questions. Dr. Pooja asks, which one is a better marker for erythroid series? CD71 gives very good staining. CD36 is okay, but I prefer CD71. On the other hand, glycophorin A is a good marker, and that can also be used. Dr. Sonali asks, please take a class on MDS and lymphoproliferative disorder. I think that will be the next round. That will be the next round whenever we take other hematology classes.
Yeah.
Dr. Malini writes down, will para-immunoblast be seen in peripheral blood in CLL? If so, how to differentiate between para-immunoblast and pro-lymphocytes? Both have nucleoli. See, all immunoblasts have basophilic cytoplasm, whether para-immunoblast or immunoblast. And the pro-lymphocytes do not have a basophilic cytoplasm. In pro-lymphocytes, the nucleolus is eccentric. It is always eccentric. That is how we differentiate the pro-lymphocytes from other lymphoid cells, while para-immunoblast will show you central nuclei. Then Dr. Apurva, again, she asked, will there be a class of MDS? I think Dr. Mithilesh Chandra will let you know as and when we have the other classes which are left over. Dr. Shiny asks, how to suspect HBH disease or alpha thalassemia from CBC? Shiny, it is very, very difficult to say, except for the fact that microcytic hypochromic picture and peripheral smear, that is what it is. What you need is a reticulocyte preparation, because reticulocyte preparation only will pick up the HBH inclusion. See, whenever there is a single alpha gene deletion, nothing we find. 2 gene deletion, again, we don't find much. But 3 gene deletion, HBH is there, and HBH can be picked up either on HPLC. That means you will do HPLC if you find target cells. So the moment you find target cells in a microcytic hypochromic picture, mild splenomegaly, think of HBH disease. Do the reticulocyte count and see the preparation for HBH inclusions. How common is lead poisoning? Dr. Apurva asks. It is not rare. Those who are working with batteries and those who are recharging the batteries, we do come across. I've seen a few cases, but I've also seen a few cases of P5N deficiency. So P5N deficiency runs in a family. We had a family and all three sons were having P5N deficiency. Initially, I thought that all of them probably had lead poisoning, but no, they didn't have. They were all tailors. So it turned out to be P5N deficiency case. Which are the must-do markers for monoblast? See, if you are doing flow, then CD14, CD64, and CD11B or CD11C. If you are doing immunohistochemistry, CD68 and CD14, and of course, whenever you are doing CD68, CD14, always do MPO, cytoplasmic MPO, and also CD34 and CD117. Dr. Upasana Das asks, in AML-M2 maturation occurs, but is it neutrophilic or eosinophilic or basophilic? 98% of the cases are neutrophilic. Occasional case, you will come across M2 with basophilic differentiation. One or two cases, you will come across eosinophilic differentiation. I have seen both eosinophilic and basophilic differentiation in AML-M2. It is rare. Ruby asks, how will you explain thrombocytopenia in a case of iron deficiency anemia? See, in iron deficiency anemia, if it is due to bleeding from any site, that will induce thrombocytosis. Thrombocytopenia is uncommon unless a patient has got iron deficiency in addition to SLE, in which you find thrombocytopenia is there, anemia is there, and then it is worsened by iron deficiency anemia. For alpha thalassemia, the best investigation, see, I told you 3 gene deletion up to 1, 2, 3. 4th gene deletion is HB Barts. Now, HB Barts is incompatible with life. That means we have to investigate only for HBH disease if it is 3 gene deletion. And for that, either reticulocyte preparation or HPLC. But if we have a patient who has got one E gene and one alpha gene, if a patient has got one beta gene and another alpha gene, difficult to investigate and come to a conclusion that this is double heterozygote for beta and alpha. Very, very difficult. What are the morphological features of eosinophilic leukemia? See, in chronic eosinophilic leukemia, there must be more than, the blast cells are usually less than 20%, but more than 5%. Along with, of course, the eosinophilic precursors, starting from pro-myelo right up to the eosinophils. Dr. Parth asks, how can we differentiate primary and secondary myelofibrosis based on aspirate and morphology? Look at the megakaryocytes. Megakaryocytes will always be looking at you, whether aspirate or morphology, if it is a case of primary myelofibrosis. For secondary myelofibrosis, you will be hunting for megakaryocytes. NSC staining, I think we'll be sending you, maybe at the next time when we take the lectures, we'll talk about NSC and other procedures. Dr. Kumar says, in infants, I find the chromatin of lymphocytes is more opened up. Is it always so? See, we've come across more large number of lymphocytes in infants. That could be one reason. Nibanita Das asks, technical point for BCB in HBH. See, what I showed you, the picture is actually brilliant crescent blue, and it should be imported. Indian BCB does not work. It does not stain HBH inclusions. Nibanita asks, one small confusion, and that is diamond blackfan syndrome usually presents early. This case is 9 years. So how to differentiate from other causes of PRCA? See, this history was made by my senior resident, so maybe this mistake you can pardon. Next is Dr. Apurva, basophilic stippling. What are the commonly encountered causes? Basophilic stippling, megaloblastic anemias, dyserythropoietic anemias, and rarely P5N deficiency. Also in primary immunodeficiency, how to explain microcytic picture. See, in primary immunodeficiency conditions, it is not a feature, microcytic picture. It could be seen. Dr. Deepa asks if PS shows leukocytosis with mild left shift and one nucleated RBC per 100 WBCs, can we call it leukoerythroblastic blood picture? Yes, if there is a mild left shift and nucleated RBCs are present, it is a leukoerythroblastic blood picture. Dr. Shiny, which marker CD71 or E-Catherine is good as IHC for identification of erythrocyte? See, for pure red cell aplasia, CD71 is a marker, not E-Catherine. E-Catherine is a marker for proerythroblast for diagnosis of pure erythroid leukemia. What is the difference between atypical and reactive lymphocytes on morphology? See, atypical and reactive. See, some of us call them as atypical, majority of us call them reactive, others call them as virocytes. How should we approach atypical lymphocytosis, especially with Downey type 2 and 3? Should we report if we come across? Yes, you should report, because nowadays, if you see the early stages of these COVID virus infection, we are seeing some atypical lymphocytes. Of course, then the lymphopenia occurs after about 4 or 5 days. But in most of these viral conditions, viral fevers, you will come across these type 2 and type 3 Downey type of cells. Dr. Priya asks, how will we report a peripheral smear in a blastic mantle cell lymphoma? We will say that the blastoid cells are present, but the chromatin is coarse, nucleoli are not seen. Advise flow cytometry or immunohistochemistry on bone marrow defined biopsy. I think with this we finish all the questions.
Yeah, Dr. Tejinder Singh, today is the concluding day, and I would like to thank you very much for your excellent presentations. All the participants have been very, very happy with your talks, and we have got so many appreciation, these SMSs, which I have been forwarding you. I would like to ask you one thing. Can I go on?
Oh, sure, please.
Our team, the DigiScan team, has been working very hard and efficiently, and has been handling all the participants proficiently, handling their queries and answering them. And the backbone of our team are Mr. Trilochan Nayak and Mr. Vikram Sharma. I would like your feedback. How have you found working of DigiScan and DigiScan team in your views?
See, it has been fantastic. I have taken 9 lectures, starting from, I think, the first lecture till today. They have been very efficient, though I have not seen any one of them. I haven't spoken to them, any of them. Yet it has been so smooth. They have been informing me at least 4 days in advance that this is the click here to enter the meeting. And it has been just fantastic. I think, and then when I asked them that I should get the answers back from the participants, so I got dot on Thursday, I got a big list from about 200 of them. And finally, also a subsequent list was sent to me. So it has been a fantastic teamwork which has been going on. And I must congratulate you, and being lucky one to have such a good team who has been looking after the whole system of these lectures and informing the delegates and the faculty in time.
Thank you so very much. It is very, very heartening and encouraging for both of them. And I would like them to say namaskar to you, at least, Vikram and Silvachan. Sir, give them your blessings. They are very young people working very hard. I have my video on. If you could put your
yes,
video
on. I can see one of them. Keep up the hard work. That is what is needed.
This is Vikram Sharma, sir. This is Vikram Sharma. And this is Mr. Trilochan Nayak.
Namaste, sir.
Keep up the hard work, and this is for you. You are young, and this is an initial stage only. I'm sure the things are going to increase with these lectures, and there is plenty of scope to further expand this system of these webinars. And what I find is that students are benefiting, and they're demanding more and more.
Yeah.
Not only the PG students, but I find that others, those who are practicing hematology, reporting hematology or cytology, they are deeply interested, and they have really practical problems that how to differentiate one from the other so that they can report. This is really heartening
Rama,
that
yeah.
you've got such a hard-working good
Thank you
team.
so very much. It's been very kind of you to encourage them. Rama, would you like to say something today at the concluding
I
session?
have enjoyed it, Tejinder. I've been hearing 2, 3 of your lectures.
Mm-hmm.
I have really enjoyed. I've also learnt a few things, and
Okay.
I always enjoy your teaching.
No, thank you
Always.
so much. Dr. Rama has been, actually, we have been meeting, I think, twice or thrice a year, but somehow this COVID thing has taken the
Yeah.
shine off, and we
Yes.
have been remembering eating kheer and kadi chawal at Gyanaji's Dhaba at Delight
Yes.
Cinema.
Yes, Tejinder.
Me,
Yeah.
Geeta, Rama, and Reshma and
Yes.
Chaturvedi,
Yes.
we used to go
Always
there.
a pleasure. Always a pleasure. Remember old times.
Oh, yes, remembering old times.
Yeah. And love your lectures.
Thank you
I
so
do.
much.
Absolutely.
Yeah.
Because I've been hearing her lecture. She has been giving lectures, webinars in various other fora. So it is always a pleasure. I still remember her first teaching to me in the very first day when she joined as a lecturer at MEMC. She showed me one basophilic red cell. And then she showed that this is a picture of macrocytic anemia. And she asked, what is this cell? I said, it is a polychromatophil. She said, no, this is basophilic. It is not polychromatophilic. It is a dyserythropoietic anemia. So this is an indication of dyserythropoiesis. I still remember and keep on teaching it to the subsequent generations of whoever comes along.
Sir, I will recount
Thank you. Thank you,
my
Tejinder.
experience with her. I was working on donovanosis, and
Okay.
she was the one who taught me how to look for donovan organisms.
Okay.
And
Yeah.
then I did a lot of work on that, but she was the initiator. She
Okay.
is very good in
Thank
picking up
you.
things.
She is
Thanks,
great in
Mithilesh.
morphology. Very, very
Geeta,
good.
for you, I would like to say that sure next year we will have programs with you which the participants are going to enjoy. They will be
Right.
looking forward to your lectures. So we will have a program next year.
Sure. That can be
Okay.
done.
So thank you. Then we say goodbye to each other.
Yes. Yes.
Yeah.
Thank you
Okay.
very
Thank
much.
you.
Thank you.
Thank you, Mithilesh, for
Thank
creating
you
this for
all.
PGs and for all pathologists.
Oh, thank you, Geeta, for being there all the time. I know it is not your subject. Huh.
No, but it was very interesting. It was brilliant, and I also liked all the responses and the differential diagnosis. I think everybody has worked hard on this, not just you, but even the people who have looked at the slides and gone through the literature. And Mithilesh, your team is excellent. Congratulations to your team.
Thank
And
you.
Rama, it was really lovely to see your face again
It's
after
so
so
good,
many
Geeta.
years. I think it's more than 10 years.
Same here. So good. So good.
Good night to
Bye.
Okay.
everybody.
Good,
And
good
Good
Okay.
night.
night.
Okay
Pranam.
then. Bye-bye.
Namaskar. Bye
Bye.
bye.